Now the white cells, we've said that the blood is about 45% cells, haven't we? Sometimes slightly less in women. They sometimes have slightly less cells, but it's not less white cells, it's the other sort of cells. Now the white cells, if you take a cubic millimetre of blood, there's probably going to be about 7,000 white cells, give or take. 6, 7, 8,000 would be normal kind of figures. White cells in a cubic millimetre of blood. So a cubic millimetre of blood is going to contain about 7,000 white cells. But as you know, you also get red cells. You also get red cells. And the red cells are erythrocytes. Erythro means red. Cyte, of course, means cells. So literally red cells. And we know that the reason these cells are red is because they contain a protein called hemoglobin. Very large protein molecule called hemoglobin. And probably the world's most common disease is iron deficiency anemia. Because to make the hemoglobin, we have to have iron. Maybe a quarter of the world's population are short of hemoglobin. They have a degree of iron deficiency anemia. It's very, very common. So, hemoglobin contains iron. Hemoglobin is a red pigment. It's the hemoglobin that makes the erythrocytes erythematused. That's what makes them red. That's why they're red cells. And if there's about 7,000 or 8,000 white blood cells per cubic millimetre of blood, the red cells, there's about 5. Lots, about 5 million. There's about 5 million red blood cells per cubic millimetre of blood. So when you first start looking at blood slides, you go to a lesson like this and you think there's white cells and red cells. You think, oh, I'll see white cells and red cells, but all you see is red cells. Go and look for ages before you see white cells. Because virtually all the cells in the blood, the vast majority of that 45%, are going to be the red blood cells, the erythrocytes. Now, the erythrocytes are red and round, and they are darker on the outside and lighter on the inside. So about a third in the middle is lighter colour, and then the darker on the outside. And the reason for this is they are biconcave discs. So if you look at them in cross section, they are biconcave discs. That's why they look darker on the outside and lighter on the inside. And the fact that they're biconcave discs increases their surface area. So it increases the rate at which oxygen can get in and out of the red cells. So in the lungs, oxygen is going to go into the red cells. The hemoglobin is going to become saturated with oxygen. Sometimes not completely saturated. What were your SATs last time you took them, your oxygen saturations? 98? Not bad. Can you see that means your lungs were working with 98% efficiency? They were oxygenating 98% of the hemoglobin molecules in the erythrocytes. It's pretty good. It's pretty good. Lungs are quite impressive, really. And of course, when we get to the tissues, the oxygen is going to go out into the tissue cells, leaving partly reduced or partly deoxygenated hemoglobin in the red cells. It doesn't all go out. Normally about 25% of it goes out. So the oxygen saturations in arterial blood are typically 98, something like that. In venous blood, the oxygen saturations go down to about 75%. So it's still oxygenated to an extent. And the other reason that these are biconcave discs is because a lot of the capillaries, well, the diameter of these cells is about 7 micrometers. That is 7/1000ths of a millimetre in diameter. But some capillaries in the body that the red cells have to go through are actually more narrow than that, particularly in the brain. And where's the other place in the body that has very narrow capillaries? The other one is the kidneys, the brain and the kidneys. So to get through, the red cells actually have to crunch down like this. And they go through crunched up. They have to squeeze through. Because why are they narrower? That is a good question. Probably so you can get more capillaries in a particular area of tissue. Probably. Unless it's some other reason. But that would kind of make sense. You get more capillaries in a particular area of tissue. Because in the kidneys you need a mass of capillaries called the glomerulus, don't you? And the brain likes lots of oxygen. So you need a lot of capillaries going through the brain tissue. So the red cells are flexible, they are deformable. They are deformable, which is very important. Because occasionally in disease processes the red cells lose their deformability, and that causes all sorts of problems. So that happens in a type of malaria called falciparum malaria. The red cells don't lose their flexibility. That's why people can go into comas. It's called cerebral malaria, because the red blood cells can't get through. Because in falciparum malaria, the red cells become inflexible. And also in sickle cell disease, the red cells become inflexible, causing awful pain in bones and places like that. So it's very important these cells are deformable. So they're the red cells, and these are made in the bone marrow. As indeed are the white cells. The white cells are also made in the bone marrow. So all the blood cells, at least in after you're born in adult life, all the blood cells are made in the bone marrow. The T cells, the T lymphocytes, trot off to the thymus gland to mature, but they're actually made in the bone marrow. So they all come from the bone marrow, including the red cells. Right, so that's the blood. 45% leukocytes, 55% erythrocytes. So leuc means white, erythro means red. It's that simple. White cells and red cells. The leukocytes and the erythrocytes. Now, it's very important to know about these because the numbers can go up or down of different types of cells. So if there wasn't enough red cells, can you see that could cause anemia? Does that make sense? You need the red cells to carry the oxygen. That could cause anemia. And there is a disease where you get too many red cells. That's called polycythemia. I guess poly means, what does poly mean? Emia. And that sounds a bit like cell, doesn't it? So many cells, blood. I wonder why that's a problem. If lack of cells causes anemia, surely polycythemia would just mean you could carry more oxygen, wouldn't it? It will get thicker. That's the problem. It gets thicker. And that means it's more prone to clotting up. You're more prone to getting blood clots. Don't really want blood clots in the blood vessels, do we? What do we call that if you get a blood clot in a blood vessel? Yeah, that would be thrombosis. And that sounds bad because I've heard of coronary arterial thrombosis. Have you heard of that? Thrombus in the coronary arteries. Doesn't sound good. Avoid that one. So we don't want it too thin because we can't carry the oxygen. We don't want it too thick. So we want the right amount of red cells. We don't want to be anemic, and we don't want to be polycythemic. Now, let's just think about a few things that can change the numbers of the white cells. Now, if there's an increase in the number of the white cells, we call that leukocytosis. That would be an increase in the number of white blood cells. So leukocytosis could clearly be an indicator of infection, couldn't it? So if we look at the white cells, and there's an increased number of the white cells all over, that could indicate infection. Might not tell us what sort of infection, but it could indicate infection. Conversely, there could be a leukopenia. And penia means not enough. So in a leukocytosis, there's an increase in the number of white cells. Normally that's good because it means that the white cells are reacting to the presence of an infection. It's good. But if there's a leukopenia for whatever reason, what is the patient at risk of? Absolutely. So leukopenic patients are at risk of infection. And if the white cell numbers are very low, they will get overwhelming sepsis and they will die quite quickly. You cannot live for very long without your white blood cells because there's always bits and bobs of infection getting in. So leukocytosis can be a sign of infection. Leukopenia we don't want because it's going to mean the patient is immunocompromised. Now, do you remember the different sorts of, remember the granulocytes? Yeah, so we could have neutrophils. And if there's an increase in the number of neutrophils, we can call that a neutrophilia. A neutrophilia will be an increase in the number of neutrophils. What might that indicate?
Bacterial.
Absolutely, bacterial infection. Well done. So neutrophilia will be an increase in the number of neutrophils. So what would be an eosinophilia? Yeah, an increase in the number of eosinophils. So can you see an eosinophilia may indicate a parasitic infection somewhere. So can you see blood tests can start to tell us what might be wrong with the patient? Is there a neutrophilia? I wonder if they've got a bacterial infection. Is there an eosinophilia? I wonder if they've got a parasitic infection. Some people will actually call this a neutrophil leukocytosis or an eosinophil leukocytosis. But the traditional names are a neutrophilia and eosinophilia. I suppose you could get a basophilia, but I can't think why you would get one of those. Alternatively, can you see you could have a neutropenia. What would that be? Neutropenia? Yeah, not enough neutrophils. Neutropenia. Does that sound quite dangerous? Again, the patients can get overwhelming infection and die if they're neutropenic. We don't want our patients to be neutropenic. So neutrophilia or neutropenia, eosinophilia, increased number of eosinophils. So we talked about agranulocytes, didn't we? So there could be a So an increase in the number of lymphocytes is called a lymphocytosis. A lymphocytosis. More lymphocytes. Increase in the number of lymphocytes. So if the patient had a leukocytosis, and the haematologists look more carefully at what cells are increasing in number, and they might find the neutrophils have not increased in number very much, but the lymphocytes have increased in number quite a lot, what might that indicate? What are lymphocytes particularly good at combating? Yeah, viral infection, yeah. So a lymphocytosis could indicate a viral infection. So what would a monocytosis be? Increase in the number of monocytes, absolutely. And this might be an indicator of chronic bacterial infection, such as tuberculosis. Doesn't guarantee it, but can you see it tells you where to start looking? By looking at the number of white cells. This is called a differential white cell count. What white cells are increased and what might that indicate?
Chronic bacterium.
Yeah. That will cause an increase in the number of monocytes. So I wonder what thrombocytopenia is. Penia, not enough. Thrombocytopenia, not enough thrombocytes, not enough platelets.
Is that what haemophilia is?
No, haemophilia is a genetic disease that causes lack of clotting factor number 8. It's quite specific. Children can get thrombocytopenia. It's an autoimmune condition where the thrombocytes can be attacked by the body's own immune system, causing thrombocytopenia. And you might recognise this by bleeding and bruising. So children could get bruising just from normal rough and tumble of childhood life because they haven't got enough thrombocytes. They're thrombocytopenic. Making them very prone to bleeding problems. Right, so that's just a few examples of how we can use differential white cell counts to tell us what might be wrong with a patient. It's starting to think about that. So have a chat about red cells now. Have a chat about what happens when you get too much or not enough red cells. And chat about what happens if you get not enough or too much of the different types of white cells.